Good morning, everyone, and welcome to this video interview with two authors of a new paper that's been published today, which is a multidisciplinary statement on the timing of elective surgery and risk assessment after SARS-CoV-2 infection. And it's now been updated, and we're in the third version. And the hope is that this new guidance will be really helpful to policymakers, administrative staff, clinicians, but most importantly, patients. And what we want to do is try and make sure that we get the key messages of the paper over to you today. So it's really great to have the authors with us on the day publication to explain why this is important and what we all need to know. So good morning, Romani, and good morning, Kareem. Perhaps, Romani, if you could just tell us who you are and what role you had in the guideline.
Thanks, Mike. So I'm Ramani Munasinger. I'm a professor of perioperative medicine and a consultant at UCL and UCL hospitals. I have a role with NHS England as the National Clinical Director for Perioperative and Critical Care. And my involvement in the guidelines was supportive. I helped to write them with Kareem leading and provide, I think, a bit of perspective from the NHS England point of view as well. Thank you.
And Kareem?
Thanks, Mike, and thanks, Ramani. I'm Kareem Al-Baghdadli. I'm a consultant anaesthetist in London, editor for Anesthesia, and have been the chair for the previous two iterations of the set of guidelines of timing of surgery following SARS-CoV-2 infection. So I chaired this set of guidelines as well, working with some outstanding people that I'm very blessed to have been able to work with, including Ramani, and that's my role here.
And it must have really been a monumental effort to, have 3 iterations of the guideline now and to achieve consensus amongst what is quite a lot of individuals, but also organisations as well. So I'm sure a lot of work has been going on behind the scenes to produce this really nice guidelines that'll be useful for everyone. So firstly, it's quite unusual to have 3 iterations so close together. So why particularly do we need a third guideline, and what's changed from the previous versions?
Yeah, thanks. You're right. Most guidelines take anywhere between 5 and 10 years to update and write and publish. But COVID was obviously very different, and things changed very rapidly. And the geography of what we're doing in perioperative care and all clinical care really has pivoted quite a lot in the last 3 years. So things have changed, obviously, and we all know things have changed. We've moved on in the pandemic. We're pretty much in an endemic phase of the pandemic. The WHO have effectively said that there's no longer a global emergency due to COVID-19. And there's been lots of things that have changed in the perioperative space with regards to SARS-CoV-2 infection, COVID-19, and timing of surgery. Firstly, we know that the variants that are currently widespread, Omicron and the various sublineages, are a little bit less severe in terms of severity of infection, and outcomes do seem to be a little bit more favorable compared with previous iterations. So now we have the new variants and the slightly less virulent forms of COVID-19. We also have had widespread vaccinations. So the populations have been vaccinated, boosted, triple boosted, quadruple boosted. On top of that, we've also got a population who now have a little bit more of a robust immunity to SARS-CoV-2, which we didn't really have very much immunity in the first wave and not as much in the second wave. And of course, competing with all of that is we've also got this massive backlog that we're trying to tackle. And what we need to do is we need to try and mitigate as many barriers to surgery as possible. So there's been lots of calls for us to reassess the data, reassess the evidence, and see if there's something that can be, that recommendations that can be kept more contemporary. So we have been forced to update the guidelines quite quickly with whatever data that we can use. And we had kind of held back and waited for slightly more robust data to be published before we updated the guidelines. In fact, people wanted us to update these guidelines end of last year, only 6 to 8 months after the second iteration of the guidelines were published. So I think that there's a number of reasons why the guidelines needed to be updated in this sort of time frame, and I'm hoping that we don't need to do as many updates in the future, and maybe this could be the last one. Who knows?
So, anything to add to that, Romany?
No, only to say that like so many other things with which are related to COVID, while it's been the most horrific experience at a personal, professional, and population level, there are some good things that have come out of it, and one of them is the way that communities have come together to produce guidance in a really rapid way, to review evidence as it comes out in a really rapid way. Yeah. And the third publication of this particular set of guidelines really makes that point.
Yeah, I agree with that. I can't remember ever seeing successive guidelines on one topic coming out so quickly and being so responsive to what's going on in the hospitals and the world out there. It is a real success story, I think, from the pandemic. So going into the recommendations, what's the main message from the guideline? Because we want people to go and read the paper, but we want to know, as the authors of that paper, can you distill a key take-home message for clinicians and for patients and for anyone else that's interested?
Yeah, I mean, unfortunately, people have taken away from the last two guidelines 2 words: 7 weeks. And I don't want that to be the message from this guideline as well, just 2 words, really. The last set of guidelines, we actually changed the title to include the words risk assessment. So we said timing and risk assessment, because that was really the emphasis last time. We spent a lot of time discussing risk assessment there. But for this set of guidelines, it is timing and it is risk assessment. And the key recommendations that we are going to be making, that if a patient is positive for SARS-CoV-2 within 2 weeks of planned surgery, then you should ideally defer unless there's clear clinical priority and a clear clinical indication for proceeding. Between 2 and 7 weeks, then you need to do a risk assessment. So patients who are low risk, having low risk surgery, which really, when we looked at the data and when you look at the numbers, that is actually the majority of patients in the NHS, and the majority of patients actually waiting for surgery. Between 2 and 7 weeks, it's probably safe to proceed if you've done that risk assessment. And if they're not in that cohort of patients that are low risk patients having low risk surgery, then you need to think about it and do a formal risk assessment and determine when you proceed with the surgery, whether you delay until 7 weeks, whether you delay until 4 weeks. We have a little bit of discussion in the manuscript, really, of how you can think about doing that risk assessment. And then anyone who's positive more than 7 weeks before surgery, unless they've got ongoing symptoms or they're really, really high risk, which is very, very rare, then you don't need to worry about SARS-CoV-2 infection, and you can proceed with surgery. So defer for the first 2 weeks, risk assess 2 to 7 weeks, and proceed beyond 7 weeks. But the emphasis as well is in that 2 to 7 week window is risk assessment.
I think that's pretty clear. And there was some quite interesting work. I know you were involved with, Romani, that's published quite recently through the use of Open Safely. And one of the messages that struck me from that paper was that perhaps showed that some of the previous guidance might have been misinterpreted in terms of how Kareem, stated 7 weeks. And I think, was it right that paper showed that clinicians seem to be adhering to that perhaps rigid rule quite rigorously, and that perhaps people weren't being risk assessed as is now being recommended again in this guidelines?
Thanks, Mike. So yeah, I mean, I think that there were 2 key purposes to the Open Safely paper. The first was to look at the adherence of the NHS in England to the first set of guidelines in particular, around which really did clearly state don't operate within 7 weeks unless there's a really good reason to do so, because those were issued in the height of the pandemic before vaccination, based on data from one big study that was international. And the paper found that there was generally very good adherence to that. What it also found is that there wasn't a massive sea change when the second set of guidelines came out. And that paper didn't look for very long after the second set of guidelines came out, but there didn't appear to be a sort of step change in people's approach. And I think that then is supported by our clinical experience, on a day-to-day basis. And we talked about this when we discussed the open safety paper in one of these podcasts, that people are very good at taking an individualized approach to the sort of, people were better at taking an individualized approach to the higher risk patient. For example, the patient that everyone felt needed to proceed because they either had an emergency condition, obviously, or they had an urgent condition like pressing cancer surgery, pressing vascular surgery, whatever. People kind of got that and could take that risk-based approach to what to do there. But our clinical experience tells us that they're not so good at looking at the lower risk patients and taking that proportionate approach. And then considering not just because it's easy to say, okay, the patient's had COVID within the last few weeks, let's not operate, without considering the wider impact that it has on that patient. What this new guideline does is really re-emphasize what the second one had said, but provide additional data to support that assertion of risk assessment, and sort of flip the recommendation on its head to say, okay, we now consider it to be reasonable to proceed after 2 weeks of an acute infection, unless there's good reason to not proceed on the basis of an individualized risk assessment. And that's just sort of flipping it a little bit, but we hope that will have the desired effect in terms of encouraging people to take a proportionate approach to risk assessment, particularly, as Karim has said, that the majority, 80% plus of patients having surgery in the NHS are having low-risk surgery done as an outpatient, where the risk of an acute COVID infection is, particularly if they've been vaccinated, is likely to be very low.
And can you remind us what the sort 2 scoring system is, and how that fits into some of the aims of the guidelines?
Thanks, Mike. So the sort 1 was a very simple risk assessment tool that was derived using really generalizable data from an NCPOD study done in 2012. And it consists of 6 variables: the type of surgery, magnitude and urgency, the patient's age, the part of the body that the operation is happening on, whether the patient has had cancer within the last 5 years, and their ASA grade as a sort of measure of their general functional capacity and physical status. And you pop those variables into an online or app-based calculator, and it gives you a 30-day mortality prediction. And the sort version 2 is the same variables, but has the additional opportunity to add clinician judgment into it. So you can put your own, based on your own clinical judgment, what you think the patient's mortality risk is within various categories. And the COVID guideline we've just published has included the sort version 2 as an example of an objective risk calculator that can be used to support this individualized decision making. And the reason that we were able to do that is because of a recent systematic review that found, that has also been published in Anesthesia, that found the sort to be the best, to have the best combination of objective validation and clinical usability. Is easy to use at the bedside out of all of the different risk assessment tools that are available for preoperative risk prediction. So using a tool like this is important for 2 reasons. So first of all, we know it works. And secondly, it's a mechanism for communicating between different people, particularly different healthcare professionals, because the less experienced early career doctor or nurse coming to you with an assessment of a patient's risk will be supported by having an assessment using an objective validated tool. and that will enable the more senior clinicians who, with the patient, are making the decisions to do so robustly. So that's the reason for using a tool like this.
And I guess it feeds into what Corinne mentioned earlier, which is about population risk and from the surgical backlogs, and they need to balance that against individual patients, as well as the consequences for those patients of delaying surgery as well. So I guess it provides what we always want, which is some way of quantifying those factors for and against surgery. Hopefully that's one of the really important things that clinicians can take away, that there is a score that they're able to use that will assist them to making these what can be very difficult decisions.
Yeah, absolutely.
And is that a way of looking at types of surgery as well? Because obviously some operations are more urgent than others. You've got someone that's having cardiac surgery or someone that's having cancer surgery. Presumably that changes things, and that can be factored in.
Yeah, so I mean, I think that's where the clinical judgment really comes into play as well, though, because the sort is a 30-day mortality prediction model. It's not anything other than that. And so the decision making about, in the context of recent COVID infection, or indeed in any context, deciding whether to proceed or not on the day, deciding what the right pathway is for a patient and the urgency of doing the operation in the context of big surgical backlogs. The biggest thing that we've got to consider is the impact of not proceeding quickly on that individual patient. And it's kind of obvious with cancer, or at least with the big cancers that have the risk of progressing quickly, like GI cancers, for example. It may not be so obvious with, for example, some patients having orthopedic surgery, where the risk is not to life, but it is to quality of life, and it is potentially to all sorts of other tangential things like patients' ability to work, their mental health, and all those sorts of things. So at the moment, I'm not aware of any objective tools that will help us make about timing of surgery, given all of those wider contexts. So that's why we need human beings with experience to talk to patients and then help balance the risks and benefits, and then make a decision collaboratively. And it's not just about anaesthetists, of course, it's about anaesthetists and surgeons and physicians, oncologists, geriatricians, whatever, given the context of the patient and the surgery.
Yeah. And I guess it's not something that AI is going to be able to help us with anytime soon either, or anything like that. We need real experienced clinicians and people involved with making decisions about people.
Yeah, because the data aren't there, I don't think, to feed into the AI models, and that's a problem. One day it'll happen, but yeah.
So you've given us 8 recommendations, and they're all there available on the infographic that's been tweeted as well today and in the paper. And we would hope that readers would go beyond those recommendations and have a look at some of the really important points that are in the paper as well. But are you able to pick one recommendation that you think is the most important, or is that too difficult?
Who's your favorite child? I mean, that's a very difficult question, isn't it? I think this conversation that Ramani, myself, and you have had, we've focused on risk assessment a lot. We've talked about risk assessment, and that's because I think the emphasis isn't on timing, is on risk assessment again. So if I were to choose any of the 8 recommendations, just having a look here, I think that it would probably be the recommendation that do risk assessment between 2 and 7 weeks. And I think that's the key. And the risk assessment is both baseline risk, but also additional risk factors. And we talk about in the previous iteration the difference between absolute and relative risk. And that's the same concept that we've kind of very subtly emphasized in this manuscript, because we don't want to teach people statistics, and I don't think it should be very complicated, but simply the concept of looking at individual patients' absolute risk increase between 2 and 7 weeks. I think that's the key recommendation to my mind. That's my favorite child. if I had to choose one.
I'd concur with that, Kareem, and I'd also say that we know, just to give a quick plug for the PQIT report that will be published quite soon, we know that we don't do the risk assessment as often as we should. So around a third of patients in the most recent PQIT cohort didn't have a risk assessment documented in an individualized risk assessment documented in their notes, and that only looks at really, really big operations that require a 2-3 day length of stay minimum and all the rest of it. So if we're not doing it for those patients, we're pretty certainly not doing it for the lower risk patients. And we're kind of obliged to, because of guidelines like this, we're also legally obliged to. So yeah, I'd agree on the basis of this guideline, but also the wider context, the risk assessment's absolutely critical.
Can I just very, very quickly add, you know, we've the idea of risk assessment and the idea of bringing the timing down between 2 to 7 weeks, I think has been is going to be really important. I hope it's going to be really important to benefit patients nationally, but also what's happened in the last couple of weeks is the ASA, the American Society of Anesthesiologists, and the Anesthesia Patient Safety Foundation, APSF, have had an opportunity to review these guidelines themselves, and they're fully supportive of them as well. And in fact, they're going to be supporting the recommendations that we're making herein. So I'm hoping that these guidelines will support safe surgery for patients beyond just the UK, actually. And the concept of risk assessment is something that people do everywhere, really, in that 2 to 7 week period, and probably for all your patients. We often do it, but we don't necessarily document it. We often do it, you know, without really explicitly thinking about it with our patients. But this is an opportunity really for us to really bring it forward and really think about that risk assessment a little bit more explicitly.
Well, I think that has been really useful for me. I hope it's been really useful for everyone who's watched as well. I would, as always, really encourage you to read the full paper, which is free to access. So do please go beyond this video and the podcast and the infographic and recommendations, and do have a read of the paper. It's quite a nice, concise paper, because a lot of this has obviously been talked about before, and this is an update. So, you know, 20 minutes, half an hour reading the paper is going to be well worth it, because I think these are really useful clinical guidelines that we can all incorporate into the work that we do every day. And we can help our patients, and we can make the best decisions for our patients, and by incorporating these guidelines into our work. So thank you very much, Ramani. Thank you very much, Kareem. And we will be watching as the discussions happen on Twitter now. So please do tweet us, please do send us letters, and please do let us know what you think as well. Thank you.